Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Good afternoon, Dr. Patel. Thanks for fitting me in on short notice. My shoulders and neck have just been giving me the gears for weeks now, and I'm hoping we can sort out what's going on and maybe get my prescriptions straightened out while we're at it.
Of course, Mr. Ashford. Please call me Maya. I'm glad you came in. Let's start with what's bothering you the most today. Take your time and walk me through what you've been feeling.
Sure thing, Maya. Well, about 6 weeks back, almost to the day, I had an emergency department visit because I woke up and it felt like bolts were being tightened right across the back of my neck and over my shoulders. It wasn't just an ache. It was like someone had clamped jumper cables to my traps. They gave me a couple of pills. One was an NSAID, the other something stronger for pain, told me to rest, and sent me home. I forget the exact names, but I only had 9 of the strong ones, 3 a day for 3 days.
That sounds miserable. Where exactly do you notice the pain now?
It starts just off the spine, right in the meat of the neck muscles, the paraspinals, I think the last doc called them. It radiates out across the top of my right shoulder, feels like a burning line whenever I turn my head, and sometimes it shoots partway down my arm, kind of a zinging feeling. The left side isn't innocent either, but it's quieter. I get this catch if I flex my head forward to read or if I lie flat on my back. Cold weather is the worst. Even walking the dog in the morning breeze makes everything seize up.
That's really helpful detail. Anything you found that makes it ease off?
The heating pad is my best friend. I'll sit with it behind my neck for 20 minutes and it loosens up a bit. I tried an over-the-counter muscle menthol camphor rub with a name that sounds suspiciously like being gay when you read it too fast. But honestly, it only distracts me for 10 minutes before the ache comes back. Those pills from the hospital actually worked pretty well, though I was nervous about what they'd do to my liver, so I rationed them.
Understandable. And day to day, how is the pain affecting what you can do?
I can still potter around the garden, and I've been using my little 10-pound dumbbells just so the muscles don't turn to jelly. But rolling over in bed is a circus. I sort of have to sit up, pivot, and then lie back down, which wakes my wife. And trust me, she's not impressed at 2 in the morning. Driving is okay as long as I don't shoulder check too often.
I appreciate how clearly you're describing this. Before we move on, any fever, rashes, or history of shingles?
No shingles that I'm aware of, and definitely no fever. Just the joy of being 68 with a rebellious neck.
All right, let's talk about your diabetes for a moment. How have your sugars been running lately?
Better than they were a year ago, but still a bit of a roller coaster. I take 22 units of the long-acting first thing in the morning and 8 to 10 units of the quick stuff with meals depending on what's on the plate. Last week, my fasting numbers were mostly in the 120s to 180s, though Tuesday I spiked to 207 after a late-night bowl of ice cream. Evenings hover in the 150s. I did have a few lows, 47 one night, then 53 a few days later, when I got distracted trimming the hedge and forgot lunch. I slug orange juice when that happens. I test 3 times a day and keep a spiral notebook, but I forgot it on the kitchen table today.
We'll work with what you remember. That's still valuable. Any nighttime lows that wake you up sweating or shaky?
Not recently, no. If anything, the lows are mid-afternoon when I push lunch a bit late.
Good to know. You have home health nurses stopping by twice a month, correct?
Yes. Omega Home Health sends Janet out every other Tuesday. She checks my vitals and pill box, but they've got a form that says I need to be homebound for Medicare to cover it, and, well, I still drive and can walk around the block, so I feel like I'm fibbing if I sign it.
Let's circle back to that. We can clarify the requirement so you're not signing anything you're uncomfortable with. For medications, besides the insulin, you're still taking a Totolac on and off, half a trazodone at night, and the cardiac meds we have on file.
That's right, and I quit cigarettes eons ago, 1965, and finally put away the pipe 4 years back. I do sneak a nicotine lozenge if I'm feeling twitchy, maybe twice a week.
All right, Len, you've painted a clear picture. Let me summarize to make sure I have it right. 6 weeks of neck and upper back pain, worse with flexion and cold, partially relieved by heat and the short course of NSAID plus opioid you had. You're managing with light weights, but nighttime turning is tough. Your fasting sugars are averaging in the 140s to 160s, with a few highs and a handful of documented lows in the 40s and 50s, mostly afternoon. You check 3 times a day and use Glargine and Aspart. And you're concerned about accurately claiming homebound status for your nursing visits. Does that sound accurate? Great. I'd like to examine your neck and shoulders now, check range of motion and muscle strength. Then we can talk about imaging and medication options. How does that sound?
Let's do it.
All right. Sit up straight and I'll stand behind you. Let me know if anything I do reproduces the pain. You've got quite a bit of tightness on the right. When I press here? Yes, there?
Yep, right there, like a lightning rod.
Okay, raise both arms like you're making a snow angel. Any pain?
I can get this left one up, but the right arm stalls halfway. That's it.
Understood. Strength feels good otherwise. Sensation and reflexes are normal. I think we should get an MRI of that right shoulder. It'll tell us whether there's a rotator cuff tear or something else structural contributing. I've put that order in today.
Makes sense. I was worried it might be something like that from years of swinging hammers.
Could be. While we wait for imaging, I'd like to start a 3-pronged plan. First, medication. Tramadol 50 milligrams every 6 hours as needed, no more than 8 in 24 hours. It's gentler on the liver than some alternatives, but it can still make you drowsy, so avoid driving until you know how you react. Second, a topical capsaicin cream, 0.1%, 3 times a day. It can sting a little at first, but if you keep at it for a week, the nerves calm down. Wash your hands thoroughly and keep it away from your eyes.
Sounds reasonable, and my beloved Totolac?
You can use it sparingly, but I'd prefer you avoid layering high-dose acetaminophen or other opioids on top. Let's protect those kidneys and that liver.
Right, you're the boss.
Third, physical therapy. I'm sending a referral for outpatient PT focused on cervical and thoracic stabilization and gentle range of motion work. They can also teach you safe ways to turn in bed and small posture tweaks for gardening.
I'll give them a call this week.
Excellent. Now, diabetes. Your numbers aren't terrible, but we can tighten them up. Keeping regular meal times will help smooth the peaks and valleys. Could you test fasting before each meal and at bedtime for the next 6 weeks and bring that notebook to our follow-up?
I can do that. My wife likes data. She'll keep me honest.
And let's look at breakfast. If you swap that cereal and banana routine for eggs or Greek yogurt a few days a week, you might knock 10 or 15 points off those morning readings.
Fair trade. I like yogurt.
Great. About Omega Home Health. Medicare defines homebound as needing considerable effort to leave home or having a medical reason that makes trips inadvisable. Driving once in a while doesn't automatically disqualify you, but we do need to phrase it accurately. I'll call Janet and we'll revise the wording so you feel comfortable signing.
Thank you. I hate feeling like I'm gaming the system.
I understand. Finally, I'd like you back here in 6 weeks to see how the pain responds and to review your MRI results and glucose logs. But if the pain worsens, the tramadol isn't enough, or you notice new numbness or weakness, call sooner. Any other questions, Len? We covered a lot.
Just one. Can I keep mowing the lawn?
Light lawn mowing is fine, but take breaks and don't crank your head to watch every stripe. Let the mower guide you, and maybe recruit that grandson you mentioned last visit for the tougher patches.
He does like the riding mower. All right, doctor. Thank you for taking the time and for explaining everything without the fancy jargon.
You're very welcome. We're a team in this. I'll have the script sent electronically to your pharmacy, and my assistant will hand you the PT info on the way out. Take care, and I'll see you in 6 weeks, hopefully with looser shoulders and steadier sugars.
Looking forward to it. See you soon, Dr. Patel.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Morning, doctor. Thanks for squeezing me in. My daughter says I sound like a kettle most nights, what with the throat burn and all.
Good morning, Mr. Delaney. I'm glad you came. Why don't you tell me in your own words what's been bothering you lately?
Well, it's a few things stacked on top of each other. The worst is that fiery feeling here, touches sternum, that shoots up into my throat right around 11:30 every night. I'll be fast asleep and bang, I'm bolt upright, coughing and reaching for a lozenge. I've learned if I shuffle to the recliner and sit up for 20 minutes, it'll settle, but it's stealing my sleep. What puzzles me is, during the day I'm fine, can eat chili if I like, no problem. It's only when I'm flat in bed.
That sounds exhausting. How long has the nightly burn been going on?
About 4 years now, ever since the old reflux crept back. You remember I had that keyhole wrap done, Nissen fundoplication. Must be 10 years ago now. Worked a treat until 2021. Since then it's a nightly dance with the pillows. I was on omeprazole twice a day, plus a swig of sucralfate before meals and ranitidine at bedtime. Lately the omeprazole feels useless, and the sucralfate glues me right up. Can't, pardon me, move my bowels unless I skip it.
I hear you. We'll sort through each medication in a moment. Anything else keeping you from feeling your best?
Balance. My Parkinson's is old news, but the tremor on my right side isn't what slows me. It's that my body turns and the legs lag behind. I've nearly toppled more times than I'll admit. Haven't hit the floor, thank heavens, but I keep the walker nearby. And the constipation. You'd think a man of 90 would talk about loftier things, but a good daily movement can make or break the day. I used to go every morning. Now it's every second day, unless I shovel in that powder, polyethylene glycol. If 3 days pass, I'm miserable.
That's an important detail. Any other changes? Weight, energy, breathing, heart symptoms?
Weight's coming down by design. Cardiologist told me to shed 35 pounds. I'm halfway there, 235 down to 200. No chest pain, no shortness of breath. I keep my BiPAP mask on all night like clockwork, so the wife, God rest her, would be proud. Only odd thing last night, my throat felt swollen for a minute when the burn woke me, but it eased.
Thank you for sharing all that. You've painted a clear picture. Let me go over what I've heard, and then we'll review the medicines together.
Fire away, doctor.
You're waking nightly around 11:30 p.m. to midnight with a burning sensation rising from your chest into your throat. Daytime, you're comfortable. You had a Nissen fundoplication about 10 years ago with symptoms returning 4 years ago. Sucralfate helps the acid but worsens your constipation. You move your bowels roughly every other day, relying on polyethylene glycol if you reach day 3, and Metamucil now and then. Parkinson's tremor is stable, but balance and turning are difficult, though you haven't fallen. You've intentionally lost 35 pounds over 18 months. No tobacco or alcohol. You use BiPAP nightly, and you haven't experienced chest pain, black stools, vomiting blood, fevers, or night sweats. Does that summary sound right?
Right on the money.
Excellent. Let's walk through your medication list to see what still serves you. You're carrying alprazolam as needed, but rarely use it?
Maybe once every few months if I get jittery before a flight. Haven't flown since COVID.
Oxybutynin 5 milligrams twice daily. How's your bladder doing?
Cuts the urgency in half. If I skip a dose, I pay for it.
Docusate 100 milligrams once daily. Your chart says it was added as a neuroprotective adjunct, but softening stools is its main job. Are you taking it?
Can't say I remember to.
Fluticasone nasal you'd like discontinued, done. Furosemide 20 milligrams daily plus potassium 10 milliequivalents. Any ankle swelling lately?
Just a whisper both sides. Right worse, because that leg's been bigger since I tore a tendon years back.
Levothyroxine 88 micrograms. Your TSH today is 5.6, a bit high. We may need to nudge the dose after we recheck in 6 weeks. Omeprazole 20 milligrams twice a day is not controlling your night reflux. We'll discontinue that and switch to pantoprazole 40 milligrams twice a day. Take it 30 minutes before breakfast and dinner. Does that sound doable?
Sure does.
Ranitidine 150 at bedtime. You're still using it even though it was pulled from shelves?
Pharmacist gives me the compounded stuff. It helps a smidge.
I'm glad it helps, but given supply issues, let's see how you do on pantoprazole first. Sucralfate suspension 1 gram 4 times a day. We'll hold it for now and reassess after endoscopy so it stops sabotaging your bowels. Polyethylene glycol as needed. Keep that. Same with Metamucil, but sip plenty of water. Melatonin 3 milligrams at bedtime. Okay for sleep?
Yes, knocks me out nicely until the burn shows up.
All right, past medical issues include Parkinson's, hypertension, chronic reflux post-fundoplication, obstructive sleep apnea, lumbar spinal stenosis, constipation, and mild stage 3A kidney disease. Surgical history, the fundoplication in several scopes, no drug allergies. Socially, you live alone, retired, no smoking or drinking. Did I miss anything?
Nope, you're thorough as always.
Good. Let me share what we found today. Blood pressure 132 over 78 sitting, solid. Heart rate 68, lungs clear, abdomen soft with normal sounds. Neurologically, I noted that gentle resting tremor in your right hand and decreased arm swing. Gaits narrow and turning is tricky, but no cogwheel rigidity. Ankle swelling is trace. Labs show creatinine 1.4 and eGFR 45, consistent with known mild kidney disease, so we'll keep an eye but no alarm bells. Any questions about those numbers?
I was worried about the kidneys. Does the pantoprazole bother them?
Pantoprazole is generally kidney-friendly. We'll repeat labs in 6 months, so long as you stay hydrated and avoid excessive NSAIDs. Speaking of monitoring, I'm ordering an INR today. Remind me, are you still on a blood thinner?
Yes, warfarin after that atrial flutter episode ages ago.
Perfect. The lab's just down the hall. Pop in there before you leave. Now, to tackle the reflux firmly, I'm referring you back to gastroenterology for an upper endoscopy. They'll look at how your RAP is holding up and check the lining of your esophagus for any irritation or Barrett's changes. You'll likely hear from their office within 2 weeks.
I'll keep the phone nearby.
For your bowels, I'd like you to restart Docusate 100 milligrams twice daily. It draws water into the stool and is gentle. Continue polyethylene glycol the moment you skip a day. Don't wait for day 3. Keep the fiber with Metamucil and chase it with a full glass of water. Any concerns about that plan?
Sounds sensible. I just like to avoid getting stuck, if you know what I mean.
Completely understand. For Parkinson's, neurology already has you for June 29. If balance worsens before then, call me and we'll move it sooner. Meanwhile, keep the walker close, remove any throw rugs, and maybe ask your daughter to test the smoke alarms since you're switching bedtime positions.
She'll be glad to boss me around.
Daughters have that gift. Regarding weight, you're at 200 pounds, which puts your BMI at 28.7. You're trending in the right direction, but don't skip meals. Smaller, balanced portions are fine. Have you noticed any appetite loss beyond choosing smaller sizes?
No, appetite's good. I just stop after one helping these days.
Great. Hydration is key, especially with fiber and the diuretic. Aim for about 2 liters a day, unless the cardiologist tells you otherwise.
Will do. Anything else on your mind, Doc?
2 quick things. First, thyroid. We'll recheck TSH in 6 weeks. If it's still high, we'll raise the levothyroxine slightly. Second, vaccinations. Your last pneumococcal booster was 9 years ago. Guidelines now recommend another at age 90 if it's been more than 5 years. Interested?
Yes, better safe than sorry.
I'll have the nurse give it before you go. To wrap up, stop omeprazole, start pantoprazole 40 milligrams twice daily before meals, pause sucralfate, keep the fiber and stool softeners INR today, GI referral, neurology on June 29th, and follow up with me in 6 months or sooner if anything flares up. How does that plan feel?
Like I came in with a knot and I'm leaving untangled. Thank you, doctor.
You're welcome, Vince. It's always a pleasure to see you. Let's get this reflux quiet so you can sleep right through midnight.
I'll hold you to that promise. See you in 6 months, maybe sooner if the phone rings at 11:30.
Deal. Take care getting home, and remember the lab and vaccine on your way out.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
Rita, have you logged into PACS this morning? Every MRI thumbnail shows a skull and crossbones icon instead of the image preview.
I saw that at 6 a.m. Radiology IT says a ransomware strain tunneled in through an outdated cardiac echo workstation. We've isolated the subnet, but anything captured after midnight is encrypted.
Our stroke protocol's on the line. Neurologists need diffusion-weighted images within 30 minutes. Can we reroute the scanners to the legacy archive?
I'm working with Siemens to set up a direct DICOM push to the off-site disaster recovery vault. The catch is the vault only stores JPEG 2000 lossless, so neuroradiology is screaming about potential artifacts.
If it's lossless, artifacts are negligible. Bigger issue is the RIS. Orders can't reconcile once the study UID changes during the manual export.
I drafted a temporary mapping table that preserves the original UID in the accession number field. It's messy, but it keeps the stroke timer intact for TPA eligibility.
Smart. Compliance will ask how we're protecting PHI during the workaround.
The export is inside our VPN and AES 256 encrypted at rest. I've logged every transfer in an audit sheet for the privacy officer.
Perfect. I'll brief neurology that images might arrive 5 minutes later than usual, but the clock for intervention remains accurate.
And I'll push the incident report to senior leadership. Maybe they'll finally budget for that network segmentation we've been pitching since last year.
Now look at question 26.
Dr. Morales, our clinical decision support AI just flagged a red alert on Mrs. Botelho's med list. Apparently, saxagliptin plus her new monoclonal migraine injection elevates cerebrospinal fluid interferon signaling.
That sounds theoretical at best. I've never seen a documented interaction between a DPP-4 inhibitor and a CGRP monoclonal.
Exactly. The AI cites a preprint from a Slovenian lab using astrocyte cell cultures exposed to supratherapeutic concentrations.
Did the model extrapolate risk without human validation again? Last month it halted methotrexate because of an in silico tomato lectin study.
Yes, and pharmacy suspended the migraine dose pending clarification, so the patient's cluster cycle is raging.
Let's override. The FDA label shows no contraindication, and the pharmacovigilance database has 0 neuroinflammatory reports for that combo.
Agreed, but we need to document why we're dismissing the AI recommendation. The board made overrides a quality metric after that adverse anticoagulation event.
I'll annotate the chart with primary literature, the post-marketing data, and serum cytokine levels we drew an hour ago. Her interferon gamma is squarely in range.
Good. I'll also ask informatics to retrain the model's weighting for unpublished in vitro data. It's overfitting fringe studies.
Meanwhile, I'll get pharmacy to release the migraine injection and schedule a follow-up neuro exam in 48 hours.
Now look at question 27.
Layla, have you seen the alert on the Da Vinci console in OR5? It just kicked the attending out mid-hysterectomy because the license server couldn't authenticate the camera module.
I was scrubbed in Suddenly, the endoscopic view froze and the robot arms stiff-locked. We had to undock and finish laparoscopically in 15 minutes.
Epic's new cloud update moved the credential handshake off-prem. If the firewall drops a packet, the system loses its certificate and reverts to safe mode.
That's a single point of failure we didn't sign up for. Biomedical engineering says Intuitive's patch restores local fallback, but legal needs proof it won't void the service contract.
In the meantime, we have 4 oncology cases on tomorrow's slate that absolutely require the robot for nerve-sparing margins.
I'm drafting a contingency plan. Convert to open if the certificate drops, but we'll need extra blood sets and an extra assistant on standby.
IT can spin up a local DNS redirect so the console thinks the license server is inside our subnet. It's hacky, but it keeps us within ASTM standards.
Do it and document the workaround in the downtime log. I'll escalate to the chief of surgery so the OR board knows why turnover may jump by 20 minutes.
Copy that. Once the vendor's patch is validated, we'll roll back the redirect and schedule an in-service for everyone who touches the robot.
I'll also flag quality improvement. We need to include cloud-dependent OEMs in our annual business continuity drills.
Now look at question 28.
Dr. Singh, our dialysis unit just reported 3 patients with unexpectedly high aluminium levels. Turns out the municipal water feed spiked after last night's pipe burst. I thought our reverse osmosis polisher could buffer up to 0.2 ppm. Are the cartridges exhausted? Worse, the auto flush valve malfunctioned, so raw city water bypassed the RO loop for 6 hours before the midnight tech noticed turbidity. That explains the sudden pruritus and bone pain labs. We need to chelate the affected patients and halt all treatments until the loop culture's clear. Facilities is trucking in ultra-pure water bladders, but they only cover 4 stations. We normally run 12. Prioritize the anuric patients and anyone with a potassium over 6. Stable residual renal folks can be bused to our satellite clinic. Notified EMS, but transportation contracts don't allow potassium emergencies after 22 without an MD ride-along. I'll sign the ride-along waivers myself and page nephrology residents to escort. Infection control also needs a report. Aluminium can seed biofilm in the loop's stagnant arms. Already sampling distal taps for ICP-MS analysis. Results by noon if we mark them stat. Good. Draft an incident brief for Alberta Health. Any adverse event tied to municipal infrastructure hits their sentinel threshold. On it, we'll present a root cause analysis at the next morbidity conference so everyone realizes a $200 valve nearly took out half our dialysis census. Agreed. And let's push procurement to replace that valve with a fail-safe version before the weekend surge.
Now look at question 29.
Carmen, the 3D-printed titanium cage batch for tomorrow's spinal fusion cases failed the porosity scan. Density is off by 3%, and QA flagged microvoids in the load-bearing struts.
I just reviewed the CT metrology overlays. Those voids line up exactly where the finite element model shows peak stress. We can't risk vertebral subsidence.
The vendor blames a power fluctuation in their electron beam melting chamber, but our consignment stock is empty because Ortho cleaned us out last week.
If we switch to peak cages, radiolucency is fine, but the surgeon planned autograft packing through lateral fenestrations unique to the titanium design.
I called Biomaterials. They can mill solid block titanium cages overnight, but we'd lose the lattice that promotes osteointegration.
Let's pivot. Use PEAK for structural support and augment with demineralized bone matrix soaked in RHBMP2 to compensate for slower fusion. I'll brief the spine team.
Document the device change in the OR pick list and notify Health Economics. The BMP add-on will trigger a cost variance alert.
I'll also alert radiology that post-op imaging will have different artifact profiles, so they need to recalibrate metal suppression algorithms before Monday.
Now look at question 30.
Dr. Yamaguchi, our tele-ICU dashboard just cross-scheduled 10 Alberta patients as if they were in Sydney. Antibiotic timers recalculated their next vancomycin trough for 14 hours from now.
That's because the vendor patched the daylight saving bug and defaulted every untagged profile to UTC plus 10. The infusion pumps are already counting down on the wrong clock.
If we follow those countdowns, the trough labs will be drawn 5 hours late, risking nephrotoxicity. Lab courier rounds can't absorb a sudden midnight run.
I'll hot patch the HL7 feed so it subtracts the erroneous offset, but the pumps need a manual reset or they'll auto-dose at the wrong intervals.
I can dispatch clinical engineers to each ICU bay, but pharmacy's smart label printers already spat out Sydney time labels for the next cycle.
Have pharmacy reprint with actual Edmonton timestamps and slap a red DST corrected sticker on each bag. Joint Commission will want traceability.
I'll email nursing leadership a quick reference card on how to override the countdown timers until the firmware syncs tonight.
And I'll open a high-severity ticket with the vendor. They need a regional time zone fallback or we'll keep chasing vancomycin ghosts every patch cycle.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.
Thank you for joining me today, Dr. Singh. The use of SGLT2 inhibitors has been expanding rapidly beyond diabetes management into chronic kidney disease. Could you start by explaining the mechanistic rationale behind this shift?
Absolutely. Initially, SGLT2 inhibitors were developed to promote glucosuria and lower blood glucose in type 2 diabetes, but research from trials like CREDENCE and DAPA-CKD demonstrated that by reducing intraglomerular pressure, modulating tubuloglomerular feedback, and attenuating renal inflammation and fibrosis, these agents confer nephroprotection even in non-diabetic CKD patients.
That's fascinating. In your clinical practice in Ontario, have you begun prescribing dapagliflozin or empagliflozin to patients without diabetes?
Yes. After Health Canada approved dapagliflozin for CKD irrespective of diabetes status in late 2023, we started offering it to patients with an eGFR down to 25 milliliters per min 1.73 milliliter and albuminuria above 200 milligrams per dl. The key is careful patient selection and education on potential side effects, like genital mycotic infections and volume depletion.
Could you walk us through a case where you've seen tangible benefits?
Certainly. Mr. Thompson, a 68-year-old retired teacher from Sudbury, presented last summer with stage 3B CKD, an eGFR of 38 milliliters per min, and a urine albumin to creatinine ratio of 450 milligrams per dl. He also had well-controlled type 2 diabetes on metformin and moderate hypertension. After discussing risks and benefits, we initiated dapagliflozin 10 milligrams daily.
What outcomes did you observe?
Within 3 months, his eGFR stabilized around 36 milliliters per min, compared to the expected annual decline of 3 to 5 milliliters per min without intervention, and his albuminuria halved to 220 milligrams per gram. He also reported improved energy levels and decreased nocturia, likely reflecting better cardiovascular volume status.
Were there any complications?
He experienced mild orthostatic dizziness during the first 2 weeks. We advised him to maintain adequate salt and fluid intake and reduce his loop diuretic by 25%. No episodes of ketoacidosis or severe volume depletion occurred.
Some nephrologists have been hesitant to add SGLT2 inhibitors to patients already on ACE inhibitors or ARBs. What's your approach to combining these therapies?
In my view, they're complementary. ACE inhibitors reduce efferent arteriolar resistance, while SGLT2 inhibitors reduce afferent resistance. Together, they synergistically lower intraglomerular pressure. We monitor serum potassium and blood pressure closely, but most patients tolerate the combination well.
Emerging data also suggest cardiovascular benefits. How do you counsel your patients regarding heart failure risk reduction?
I explain that landmark trials, like Emperor Reduced and Deliver, showed a roughly 30% reduction in heart failure hospitalizations, even in individuals with preserved ejection fraction. So beyond kidney protection, these drugs improve overall survival and quality of life.
Switching gears, how do you handle prescribing in rural or indigenous communities with limited access to specialty follow-up?
Telemedicine has become invaluable. Through our provincial e-consult program, we work with primary care providers in remote communities. We provide virtual education sessions on monitoring parameters, blood pressure, renal labs, symptoms of volume overload, and ensure local labs can process urine albumin tests.
Have you encountered adherence challenges?
Cost can be prohibitive. Although covered by most provincial drug plans for diabetes, non-diabetic CKD coverage varies. We often apply for special authorizations or connect patients with patient assistance programs. Education on the once-daily dosing and tolerability also helps maintain adherence.
Looking ahead, are there novel agents or combination approaches on the horizon?
Certainly. Dual SGLT1 tau inhibitors like sotagliflozin are under investigation for broader metabolic benefits, and non-steroidal mineralocorticoid receptor antagonists, when combined with SGLT2 inhibitors, may further reduce albuminuria and slow CKD progression. We'll soon have trial data from Figaro CKD to guide us.
Finally, what key takeaways should primary care physicians in Canada remember?
First, screen CKD actively with EGFR and albuminuria. Second, consider early initiation of SGLT2 inhibitors in eligible patients, diabetic or not. Third, coordinate care with nephrology via telehealth to manage side effects. And fourth, advocate for formulary coverage to ensure equitable access across all provinces.
Dr. Singh, thank you for sharing your insights and the illustrative case of Mr. Thompson. It's been an enlightening discussion on transforming CKD care in Canada.
Thank you for having me. I hope more clinicians will embrace these advances to improve patient outcomes nationwide.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Good afternoon, everyone. I want to invite you to imagine the moment when an email pings into your inbox saying the words every oncologist dreams of sending to a patient. Your scans are clear. Today I'm sharing the story behind that email, a journey that started in a small genomics lab in Melbourne and has rippled into operating theaters and infusion suites across Australia, the US, and the UK. We'll travel through ribosomes, courier lipid nanoparticles, brisk melanoma clinics, and the everyday bravery of one construction foreman named Jacob, because this is a story about the rise of personalized mRNA cancer vaccines and what they mean for modern oncology. First, the backdrop. In 2018, the New England Journal of Medicine published data from Sahin and colleagues showing that custom-built mRNA vaccines encoding neoantigens could expand high-affinity CD8 mice T cells in patients with advanced melanoma. That same year, a Cambridge group ran a phase 1 dose escalation trial in pancreatic cancer and documented T cell infiltration in lesions that previously looked immunologically barren. The concept was simple but audacious. Biopsy the tumor, sequence its DNA, use algorithmic ranking to pick the most immunogenic mutations, then ship that information into an mRNA strand so the patient's own ribosomes could print out a wanted poster for their immune system. The promise was that the poster would be so specific that collateral damage would shrink and efficacy would rise. Now let me introduce Jacob. He's 53, born in Geelong, drinks long blacks that could strip varnish, and until last year thought messenger RNA was one of those WhatsApp things. Jacob had stage 3C cutaneous melanoma on his upper back excised 2 years ago, followed by adjuvant pembrolizumab. 19 months later, he felt a lump beneath his left axilla while tightening the lug nuts on a client's steel staircase. PET-CT lit up 3 lymph nodes and a 1.4 centimeter deposit in the right lung apex. His oncologist, Dr. Lang, enrolled him in the Australian arm of the mRNA 4157 V940 plus pembrolizumab trial that had just reported a 49% reduction in recurrence or death compared with PD-1 monotherapy at ASCO 2024. Jacob's tumor exome was sequenced on an Illumina NovaSeq, spitting out 1.8 gigabases of data in 48 hours. A cloud-based neoantigen predictor ranked 27 candidate mutations by MHC class I binding affinity and clonality. The top 16 were fed into a 3,720 nucleotide mRNA blueprint. 4 weeks later, a chilled parcel arrived containing lipid-encapsulated strands, suspended in a buffer that looks like water but represents a decade of nanoparticle engineering to evade complement activation and Kupffer cell uptake. At Jacob's first vaccination, the nurse pushed 0.5 milliliters into his deltoid at 9 a.m. By lunchtime, he felt flu-like. Paracetamol handled it. What happened inside was far more dramatic. Dendritic cells took up the nanoparticles, translated the mRNA, displayed neoantigen peptides, and migrated to his axillary nodes. There, autologous T cells encountered a molecular billboard declaring the identity of every mutant epitope driving his malignancy. Within 72 hours, flow cytometry of peripheral blood showed a 10-fold expansion of neoantigen-specific CD8 MI cells, something the Keynote 716 pembrolizumab-only cohort never displayed. 3 months later, Jacob's repeat PET-CT was not just stable. The lung nodule had vanished, and the lymph nodes shrank below the pathologic threshold. We often talk about RECIST responses, but the more poignant metric was Jacob's response when he realized he could lift boxes overhead again without the gnawing anxiety of metastasis. He told me, "Doc, it's like the fear dial got turned down from 11 to 5. That qualitative shift in psychological morbidity is rarely captured in Kaplan-Meier curves, yet it's what families remember. Let's step back from Jacob and examine why this worked when earlier peptide vaccines faltered. Firstly, mRNA permits polyepitope delivery in a single construct, bypassing the HLA restriction bottleneck that doomed many peptide cocktails. Secondly, transient expression means minimal risk of insertional mutagenesis, a concern that still shadows viral vector gene therapy. Thirdly, the mRNA platform is unbelievably agile. When Jacob's tumor sequencing revealed a new KRAS G12D subclone on ctDNA after cycle 2, a supplemental booster encoding that epitope was printed within 9 days, something unimaginable with protein-based manufacturing pipelines. Critics rightly highlight lingering questions. What is the durability of memory T-cell responses after the final booster? How many neoantigens generate deleterious cross-reactivity? Could epigraph algorithms reduce manufacturing time from weeks to days? Those questions drive a dozen ongoing trials, including a University of Oxford study pairing mRNA vaccines with oncolytic virotherapy to inflame cold, microsatellite stable colorectal tumors. Meanwhile, regulators debate whether bespoke GMP facilities can scale globally without bankrupting healthcare systems, a debate complicated by the fact that each batch is, by definition, unique to one patient. Yet pragmatic progress continues. The U.S. FDA granted breakthrough therapy designation to mRNA 4157 in April 2025, citing event-free survival gains in stage 3B/C melanoma. NICE in the UK has launched an accelerated access pathway, exploring hospital-based micromanufacturing hubs co-located with genomic sequencing centers, and Australia's Pharmaceutical Benefits Advisory Committee is modeling cost-effectiveness, assuming a 10-year relapse-free benefit. Even insurers, traditionally late to the table, view these vaccines as cheaper than the cumulative costs of chronic immune-related adverse events from indefinite checkpoint blockade. Where does this leave clinicians in everyday practice? It leaves us needing new skill sets, proficiency in interpreting variant allele frequencies, comfort discussing cloud-based data security with patients, and vigilance for a side effect profile that looks more like a brisk flu vaccine than traditional chemotherapy. It leaves tumor boards inviting bioinformaticians alongside surgeons. It leaves pathology labs racing to report tumor mutational burden inside the same turnaround window as ERPR and HER2 scores. And most importantly, it leaves us with stories like Jacob's. 6 months after his complete metabolic response, he resumed coaching his daughter's under-12 netball team. The day he forwarded me that scan report, he accompanied it with a photo of the netball squad holding a cardboard sign that read, "Science saved our coach." We talk about hazard ratios, but moments like that distill the essence of why we stand on this stage. They remind us that the ultimate metric isn't median progression-free survival. It's reclaimed birthdays, revived family rituals, and construction foremen who can spin a netball in one hand while lifting steel beams with the other. So as you leave this hall, remember Jacob's nanoparticles looping through his circulation. Remember the ribosomes churning out bespoke peptides. And remember that we are living at the hinge of an era when oncology treatment is no longer limited to what drug companies have on the shelf, but can instead reflect the exact genomic fingerprint of an individual tumor. We owe it to our patients to push that hinge wide open. Thank you.